Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Forum podcast, where I am joined by Dr. Ron Adelman. Dr. Adelman is the consultant and chair of ophthalmology at the Mayo Clinic, Florida, and like myself is an emeritus professor for Ron, Yale University, and for myself, Bascom Palmer. We're going to discuss an article that he has spectacular expertise with his master's in both business and public health, Trends in Medicare Reimbursement and Service Volume of Vitreoretinal Procedures from 2000 to 2021. Welcome, Dr. Adelman.
Thank you, Dr. Murray. An honor to be talking with you.
Good to have you here. It's a real pleasure. So, Ron, I think that you looked at this data in a relatively unique way, and it's a relatively unique data set. Can you take us through, how you kind of structured your manuscript, what data you had access to, how you were able to use it, and then what analysis led to some of the conclusions that you have?
So we looked at the Medicare data, and Medicare data is publicly available on its website. We looked at the volume of vitreoretinal procedures from 2000 to 2021. So it was a 21-year period comparison. We looked at the volume of the vitrectomies, volume of scrub buckle, lasers, and pneumatic retinopathy, among other procedures such as photodynamic therapy, and looked at the trend. Also, we looked at the reimbursement that has happened throughout these 21 years and what was the trend in reimbursement and what was the correlation between the volume of the procedure versus reimbursement. For example, intravitreal injection has significantly increased. So what happened to its reimbursement, and what is the reimbursement when we adjust it for inflation?
Dr. Adelman, one of the things that Dr. John Thompson always says is the more we start to do something, the less the government wants to pay us for it. So it's kind of interesting that it seems the payments stay relatively fixed as a pot, but they change hugely in their individual focus. Did you see that with intravitreal injections?
Yes, throughout this 21 year, the injections have increased about 1,000-fold. And at the same time, the reimbursement for injection, inflation adjusted, was decreased by over 60%. So what we are getting now for an injection, considering the inflation, is about 1/3 of what we used to get in 2001.
And it's interesting too, because when you look worldwide, the intravitreal injections are the number one performed surgical procedure. And there were about 15.1 million injections this last year. So this potentially is a hugely impactful procedure. And the other thing I find interesting, Ron, as you know, is that we don't usually inject without assessing and evaluating our patients and using imaging to document status as we inject.
We often do OCT when we do injection, and reimbursement for OCT, inflation adjusted, has significantly decreased.
Another thing we've seen too, besides the impact on the OCT codes that are volume driven, it's been interesting that anytime we introduce a new relative code, it tends to have a negative impact on reimbursement for existing codes. So with the OCTA codes launching, it looks as if the impact on OCT in terms of reimbursement will be significant. And most of our practices are heavily OCT based, and many of our practices have very little OCTA. How do you feel one should affect the other?
So OCT and OCTA from a physician point of view should not affect each other, but from the payers and insurance coverage, they impact each other. Many times OCT, OCTA, and fundus photos, they are bundled together. So if you do three studies, you are being paid for one out of three. And that impacts the time that physician spends, the equipment that is used, and also the technician's time. So it's actually doing three type of studies and being paid for one.
The other thing we're seeing this shift where it used to be that we believed we made our money in the operating room, and the operating room was where you went to do surgical, procedures for your patients. We're now seeing the shift where more and more people are less interested in going to the OR and staying in the clinic. And the clinic volumes and clinic reimbursements seem to have increased relatively greater proportionally than the decline has occurred in surgical procedures. Did your data suggest that was true also?
So what happens is the volume of the office procedures significantly increased, and specifically is intravitreal injection. That has increased 1,000-fold. While when we look at the other codes, most of them had declined over the course of years. Many procedures became less invasive, and we can do office procedures. For example, many of the diabetic vitrectomies that we used to do now is managed by intravitreal injections. And many of there was submacular surgery for AMD, and that's not done anymore because AMD is managed by intravitreal injection. So office procedures are becoming more and more common. And Hour per hour, and when we calculate the time that a physician spends in the office versus in the operating room, it seems that operating room reimbursement is less than office procedures.
The other thing we're seeing is that part of the decline I have heard is that it is getting harder and harder to get into an operating room as a vitreoretinal surgeon. That's an indirect event that clearly can affect the volume numbers. How do you kind of parse that out when you look for something specific?
So we did not study the access to the operating room, but the general consensus of physician is access to the operating room has become more difficult, and that has a, an impact on the volume of the surgeries that could be done.
And then, Ron, it seems to me that my perception is that medical care delivered by physicians seems to be progressively devalued. There's very few things in this crazy world where you can see that you get paid less to do more. Just on a philosophical level, why do you think that's happening? And is there a way that we can address that as we go forward as a profession?
When we looked at the data in a 21-year period, the reimbursement after adjusting for inflation was 32%, had 32% decline. It's about one third less than what it used to be 20 years earlier. And in most of the other professions, we see that the income has gone up, but here, inflation adjusted, it has gone down. Um, it seems like there is a pot of money for healthcare, and as population ages and as there are more procedures and more healthcare being done per person, then the same amount of money is divided by more procedures and more people. So per procedure, per patient, physicians are being paid less.
I've always said when I'm with the residents and the fellows that we don't do this for the money. And I think your study really tells us that we don't do this for the money. Any last comments, Dr. Edelman?
I think our goal is to help a patient to have the best outcome, to have the best health. At the same time, to encourage the next generation of brightest people to come to medicine, it's important that reimbursement follows the inflation, and that way there would be some more encouragement for brightest and smartest people to join medicine and advance the healthcare, advance the health of our population for next generation.
Right. I really keep saying that it's about being fair. So I think that you need to understand that medicine is a unique opportunity for us. We provide a service that is like no other, truly. And the outcomes in retina in particular have been relatively spectacular. Our diabetics, our neovascular AMD patients. So I feel we're doing so much more, but we're having to do it for so much less.
That's a great point.
Well, Dr. Adelman, thank you for joining us, and lots of detail, lots of granularity in your manuscript. So I hope everybody got a little bit of a tease about how much data is available to look at this active shift in Medicare reimbursement over a 2-decade period. Dr. Adelman, thank you very much for joining us.
Thank you, Dr. Murray.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD Forum on the ASRS website to learn more. See you soon.